Good afternoon, everyone. I'm honored to be speaking with you today. I will be discussing imaging in bariatric surgery, a guide to common postoperative complications. In this presentation, we will go through definition of morbid obesity, bariatric surgery prevalence, common bariatric surgeries, and some of the common postoperative complications. Morbid obesity is defined as being 100 pounds above ideal weight, twice ideal body weight, or body mass index of 40 kg per meter square or more. Bariatric surgery prevalence. Bariatric surgeries have been increasing in prevalence as the obesity epidemic climbs in the United States and in the whole world. During the past 2 decades, bariatric surgery has become an increasingly popular form of treatment for morbid obesity. The most common 3 bariatric surgeries are Roux-en-Y gastric bypass, which is a restrictive procedure with creation of a small gastric pouch from the proximal stomach with exclusion of the distal stomach, creation of gastrojejunostomy anastomosis, and this is called the Roux limb, and then creation of anastomosis between the Roux limb and the excluded stomach and the proximal small bowel through a jejunostomy. Second is the laparoscopic adjustable gastric banding. It's also a restrictive procedure, reversible, using a gastric band at the proximal stomach, and this band is connected to a fluid-filled tube and a subcutaneous port or reservoir to allow band adjustment. And then the sleeve gastrectomy, which is in which about 2/3 of the stomach is permanently removed. So I will review some of the most common complications after each of these 3 surgeries. Roux-en-Y gastric bypass, the complications or the postoperative complications can be divided into early and late. Early complication like leak. And here, this is a CT abdomen with intravenous and oral contrast in sagittal and axial planes, showing extraluminal oral contrast with extraluminal air foci near the staple line or near the anastomosis, which reflects leak. One of the early and late complications after Roux-en-Y gastric bypass, gastrointestinal bleeding. This is CT abdomen and pelvis with intravenous contrast. A and C are arterial phases, B and D are venous phases, showing a sizable hematoma related to the excluded stomach with a focus of active contrast extravasation, denoting gastric bleeding. Also stomal edema and stenosis. At the site of the jejunostomy, here there is stricture leading to proximal obstruction with dilatation of the stomach and the esophagus. Fistulization. Fistulization between the Roux limb and the excluded stomach. And here in this patient, axial CT of the abdomen and pelvis with intravenous and oral contrast. The oral contrast entered the Roux limb and rapidly or immediately entered the excluded stomach, which denotes presence of fistula between the Roux limb and the excluded stomach. The same patient in MEP coronal CT of the abdomen and pelvis with intravenous and oral contrast. Again, this is the fistulous tract in between the Roux limb and the excluded stomach. Marginal ulcers. This is AP fluoroscopy imaging of supine patient after ingestion of barium, showing a small outpouching here arising from the proximal jejunum, denoting marginal ulcer, and this marginal ulcer can perforate, leading to pneumoperitoneum, like in this patient. Also, intussusception could be a complication after Roux-en-Y gastric bypass. This coronal CT abdomen and pelvis with intravenous contrast for a patient with history of raw and wide gastric bypass showing jejunal intussusception at the left side of the abdomen. And still no proximal bowel dilatation. But at this patient showing also jejunal intussusception at the left side of the abdomen with proximal dilatation of the bowel, which means obstruction. EB fluoroscopy image with patient in supine position after ingestion of barium, showing jejunal intussusception here in the left side of the abdomen. Laparoscopic adjustable gastric banding. I will review some of the complications that could happen after the surgery. Early, like gastric band malpositioning. This patient showing malpositioning of the gastric band. It should be seen at the proximal stomach, but it's displaced distally, leading to a markedly dilated stomach and esophagus, which means a gastric outlet obstruction. Port site infection, as I said before, in the gastric banding, the gastric band is connected through a tube to a subcutaneous reservoir or port in the subcutaneous tissue. So the port site or the subcutaneous port site can be infected. In this patient, showing displaced or misplaced gastric band with allocated fluid collection tracking along the tube towards the subcutaneous tissue. Also, gastric band slippage can be happened, and this can be assessed through calculation of the phi angle, as Dr. Ahmed Himami mentioned before in his lecture. This patient, after gastric banding, showing gastric band displacement with gastroesophageal reflux. Some of the postoperative complications of the sleeve gastrectomy, it can be divided into early and late complications. Bleeding, like this patient. Here we have multiple axial slices of CT abdomen with contrast. A, C, and E are arterial phases. B, D, and F images are venous phases, showing hemoperitoneum in the perihepatic and perisplenic region, as well as a focus of active contrast extravasation, consistent with active bleeding. Early and late, after sleeve gastrectomy, like gastric leakage and perforation. Multiple coronal slices of CT of the abdomen with intravenous and oral contrast, showing extraluminal contrast extravasation, as well as foci of pneumoperitoneum consistent with leak. The late complications after sleeve gastrectomy, it could be gastric outlet obstruction or GERD, and that's it. Thank you.
Thank you,